Hello, everyone. Welcome back to the afternoon session of the 10th Annual Virginia Patient Safety Summit. My name is Christy Morgan, and I am the manager of the Quality Research Institute at Sentara Healthcare. I've had the pleasure of serving as the co-chair of the planning committee for this year's Patient Safety Summit. I hope that you were able to enjoy the videos that were shown during the intermission that acknowledged some of our partners and celebrated the quality and happening in Virginia hospitals during the past 10 years. Indeed, good things are happening in healthcare across the Commonwealth. A recording of all the videos that were shown during the intermission will be available for viewing on the VHHA website on the Patient Safety Summit webpage. In preparation for this year's summit, the Planning Committee issued a call for quality improvement projects for hospitals across Virginia. Over 40 projects were submitted, and 25 of those were turned into 10-minute video presentations. Because we are not able to present all 25 of those projects today, we have made all 25 recordings available on the VHHA website. A link to those videos will be placed in the chat box. For the next 40 minutes, you will be treated to 4 of those quality improvement projects from 4 different Virginia organizations. The first project is titled Decreasing Infection-Related Decompensation for ED Children at High Risk, using artificial intelligence and a team-based communication model, and is presented by a team from the Children's Hospital of the King's Daughters in Norfolk. The second project is titled Ice Ice Baby, Reducing Hypothermia in Neonates Admitted to the Neonatal Intensive Care Unit, and is presented by a team from the Inova Children's Hospital in Fairfax. The third project is titled Central Line Acquired Bloodstream Infections, and is presented by a team from the HCA Chippenham Hospital in Richmond. And the fourth project is titled Mind Your Meds, Safe Opioid Medication Use and Disposal, and is presented by a team with the Virginia Geriatric Education Center at VCU in Richmond. Thank you all again for being with us this afternoon, and we hope you enjoy these 4 quality and safety improvement project presentations and take time later to review the other projects that are posted on the VHHA website.
Hello, everyone. My name is Elizabeth Martinez, and I am a Quality Improvement Specialist with the Children's Hospital of the King's Daughters in Norfolk, Virginia. And I'm here to talk to you about decreasing infection-related decompensation for emergency department children at high risk using artificial intelligence and a team-based communication model. We all know that pediatric sepsis is a leading cause of death amongst children, accounting for at least 75,000 deaths annually. Despite new electronic alert systems in many hospitals, diagnosis of pediatric sepsis and delivery of timely interventions remains elusive, given the multitude of clinical presentations, lack of treatment consensus, and minimal interdisciplinary team communication. What we've done is we've combined the use of our existing artificial intelligence system, which is called Children at High Risk Alert Tool, or CAR Alert Tool, with team-based communication to trigger recommended therapies and decrease the number of patients with infection-related decompensation, or IRD, within 48 hours of emergency department arrival. So the CAR Alert Tool uses a predictive algorithm based on normal and abnormal vital sign standards from over 1 million patients, identification of gold standard sepsis cases, and statistical techniques that assign weights to each factor that results in the optimal combination of sensitivity, alert firing rate, and positive predictive value. All patients who fired the simulated and the live version of the CAR Alert Tool in the ED between January 2017 and July 2020 were included in our project. CAR Alert Tool is a predictive electronic alert tool, as I mentioned, that is in the emergency department and looks at various factors to identify patients at risk for infection-related decompensation within the next 48 hours. IRD was defined as one or more body systems with acute organ dysfunction that developed within 48 hours of ED arrival. Iterative improvements included implementation of a nurse and provider diet assessment, graphical interface redesign using visual cues, some treatment bundles, and electronic huddles, or what we like to call pit stops, and standardized order sets. So let's go into a little more detail on some of the major tests of change that we did throughout this project. First, the diet assessment. This is where the nurse and the provider go and assess the patient once the car alert tool has fired. The goal is to assess the patient within 10 minutes of firing. Second, there was a major redesign of the graphical interface and visual cues to coincide with the car theme. So this is a diagram I'm just going to walk you through. So first, the car alert tool will fire due to some abnormalities that it's registered due to those weighted factors. And if it has a score of 5 or greater, then this red checkered flag will appear on the tracking board, prompting the nurse and the provider to go in and assess the patient. And sometimes in the care team, they'll also have an ED tech or a respiratory therapist. They go in and assess the patient and decide upon an appropriate stoplight color. And I'm going to explain how they arrive at that stoplight color here. So a stoplight color, red, yellow, or green, will indicate both how ill-appearing the patient is at that time, as well as resources needed, including the frequency of reassessment. So they'll think, is the patient ill-appearing, yes or no? If so, then they ask themselves how often they want that patient reassessed and choose an appropriate stoplight color. If they're not ill-appearing, then they're asking the question, well, does this patient require any expedited interventions or resources, whether they're existing or new orders? If so, again, they'll ask how frequent the reassessment they want. And then if not, then typically you're ending up at a green stoplight color. So once they've agreed upon a stoplight color and completed both of their respective forms, that color, red, yellow, or green, will show up on the tracking board. Next, we implemented treatment bundles. Now, initially, these were only recommendations, and then they've kind of progressed to almost a requirement, but we're not quite there yet. This is what we call the pit stop guide. So during pit stops or huddles, the team would be able to reference this and see the recommended bundles for each stoplight color. Some of the major differences in this are the times and assessment frequency. So you'll notice the red stoplight has a higher frequency of reassessment and a more expedited vascular access and IV bolus interventions, whereas the yellow, you've got 30 minutes for those. And then the green just indicates the reassessment time of 2 hours. Pit stops or huddles were an essential component to the workflow. Initially, we completed a PDSA on paper, and then later on, we were able to make the process electronic and part of our EMR. So upon the dyad assessment, you've got the car tool that fires, you do their assessment, and they choose a stoplight color. A nursing task, shown by this green cross here, would activate automatically, and depending on the stoplight color chosen, would then prompt the team to assess every 30, 60, or 120 minutes. And during the course of the treatment, the dyad team could change the stoplight color manually, which would change the pit stop frequency. The only other way to change the stoplight color would be as if the tool refired automatically due to receiving new abnormal factors, increasing the car score, which would then prompt the red checkered flag and a new assessment, etc. These pit stops allowed the care team to not only reassess the patient together, but to ensure everyone knew the status of orders and what the plan was going forward. And finally, in an effort to make ordering the bundle elements more efficient, we developed car, red, and yellow order sets. These are what they look like, and essentially you've got monitoring, peripheral IV access, antibiotics, IV fluids, and some labs. The major differences, again, between the two order sets are the timing and some extra orders on the red stoplight power plan or order set, like length, level of consciousness, assessment, urinary catheter, and some extra labs. So let's take a look at some results. After our various tests of change, how did we do? This chart looks at the percent of initial pit stops that were completed on car patients that had either a red or a yellow stoplight activated. A shift in ED culture toward improving communication and team assessment was evidenced by the increase from 8.3% in the initial pit stops before electronic implementation to 63% post-electronic implementation for the car-positive patients that had either a red or yellow activated. In addition, bacterial cultures collected in the ED rose from 45% prior to implementation of the car alert tool to 56% after electronic pit stop workflow. This illustrates the shift in culture toward a willingness to consider an infection-related cause. Now here, what we're looking at is IV or IM antibiotic administration by 3 hours post-car firing. The percent of antibiotics received by 3 hours post-alert increased from 34.6% before the car alert tool to 45.1% after electronic pit stop implementation. This data includes patients who received antibiotics prior to arrival, like at an outside facility or during our downtime. This increase was a major win for our organization, as the culture around antibiotic ordering was a major barrier. We still have work to do, but we've made great strides in this area. This chart looks or displays our outcome measure. The percent of CAR patients with a positive culture with acute organ dysfunction within 48 hours of ED arrival decreased from 50% pre-CAR alert tool to 24.1% post-implementation of the electronic pit stops. Now, when I say positive culture, I'm referring to either blood, CSF, urine, or a sterile cavity fluid that was positive for bacteria. This wouldn't include viral or fungal sources. So what you're seeing here is a 25.9% decrease in acute organ dysfunction in this patient population. So the combination of workflow focused on standardized reassessment, team communication with situational awareness, and our artificial intelligence, the CAR alert tool, contributed to a significant decrease in acute organ dysfunction within 48 hours of ED arrival in these high-risk patients. And it took all these elements together, working in unison, to achieve our aim. Thank you very much for the opportunity to speak with you today. I'd be happy to answer any questions at this time.
Good afternoon, everyone. My name is Allison Barberia, and I am a quality consultant at Inova Children's Hospital in Falls Church, Virginia. Today, I'm joined by Jennifer Bodnark and Lynn Hardy, who are members of our women's and NICU team, to talk about our work around reducing hypothermia in neonates admitted to the neonatal intensive care unit. Just a little bit of background about Inova Children's Hospital. We are a 226-bed children's hospital in Northern Virginia, including a 108-bed level 4 NICU. We had over 27,000 NICU patient days in 2020, and we have over 10,000 babies born on this campus every single year. A little bit of a background about what we're going to be discussing today. We are going to be discussing neonatal hypothermia on admission to the NICU. When we looked back at some of our data surrounding Vaughan and US News, it revealed that we were not meeting the benchmark for the amount of cold babies that we had coming into our NICU. The team had previously done work on normothermia in our smallest infants, less than 1,500 grams, back in 2017. However, the rates didn't improve like they should have. When we looked at the data analysis, we actually realized that we had a gap for our babies who were 1,500 grams to 2,500 grams, and making sure that we were addressing thermoregulation in that population. So what we did is we assessed national guidelines, and we actually extended thermoregulation interventions to the IUGR SGA population, and we standardized this with a checklist across system, women's, and pediatric service line. This is a quick look at the team that we had involved in this work. A vast array of expertise, including physicians, nurses, quality, and specialists, our outcome specialist, who was essential in our data analysis. So looking back at our baseline performance, it revealed that 19% of the inborn babies coming into the NICU had an admission temperature less than 36 degrees Celsius, meeting hypothermia definition. It revealed through data analysis that our largest opportunity was actually in the 1,500 gram to 2,500 gram babies who were born in the OR via C-section. So we set a goal for ourselves. We set a goal that we wanted to reduce the amount of neonates with hypothermia coming from our inborn maternity services from 19% to less than 10% by these interventions that I'm going to talk about with our team on the next slides.
So we started with some things that we could do right away, called them just do it's. And one of the things we could easily start was to expand our current thermoregulation interventions from neonates less than 29 weeks to include those all less than 32 weeks, as well as patients that were measuring less than the 10th percentile IUGR or SGA patients.
And then we also worked with our engineering department to complete work that was needed to activate the warmers that were built into our ceiling and the baby alcoves in our ORs that had never been fully operational when our hospital was built 5 years ago.
The next thing we did in terms of tests of change, so things that took a little bit longer, were we implemented a standard thermoregulation checklist, including some precautions about hyperthermia. And as far as that checklist goes, it's actually double-sided. One side is for the infants born less than 32 weeks and the others for the SGA or IUGR infants. This was more used as a research resource, was not entered into our EMR. One thing that we did was we trialed it with some nurses that attend deliveries. One of our champions on our team is actually a member of that team, and she was able to communicate the importance of this. And then we put the communication to staff members in huddles and email, and we posted it on our Canvas site. And in the NICU, the nurses can print that checklist before they go to a delivery.
And then we also queried women's hospitals similar to ours around the country. And we found out that they were keeping their C-section ORs between 71 and 74 degrees compared to ours, which were about 68 to 69 degrees. So we worked with infection prevention and came up with a temperature of 72 degrees that we all agreed on. And so we decided to increase the temperature of the ORs for our growth restricted babies and our low birth weight babies. So that was a change in the standard work for our nurses. And then we also added a repeat temperature check for the babies before leaving the OR. That wasn't being done. So we added that in. And then every month we review the cases for any outliers that we have to look for any trends and any opportunities. And then next slide.
This is just a quick highlight of the delivery checklist that Lynn mentioned earlier. As you can see, it's very clearly laid out according to the workflow of the nurses and the phases of care for the patients.
So this graph here shows the percent of the inborn NICU admissions that have a temperature of less than 36 degrees Celsius. And it covers a time span of 2019 to 2020. The blue bars represent all the NICU admissions, and then the dark blue line represents the number of babies that were below our goal temp. And again, our goal was less than 10%, and we ended up ending 2020 with a rate of 9.2% after the interventions that you can see that we initiated in early 2020.
I wanted to take a look at our rate of neonates with an admission temperature of less than 36 to adjust for admission volume differences per month. So this is a control chart, and the red line is the center line. The blue line is our rate per 1,000 inborn NICU admissions, and the green line is our upper control limit. As you can see, we had a pretty dramatic shift downwards, and down is a positive direction in this case. So we had a downshift in our number of cold babies, and we sustained this throughout our year, which was really great. So I just wanted to recognize our team. This is something that we have hardwired. We continue to talk about on a daily basis and make sure that we are doing the best we can for our babies. We wanted to reflect very quickly on a few lessons learned when we came into this. So this is actually not the first time that we've looked at this issue before. And I think what we realized is we shouldn't make assumptions about where we think the problem lies. We really need to go to the data and say, is it our smallest babies, or is it actually our babies who are in different population, and where are they coming from? So I think that is something that we learned. We also had a lot of success in motivating our team because we identified a few just do it's that people were very happy about, including activating our warmer alcoves in the women's ORs. And lastly, use data to make your case. It was a practice change to increase the temperatures in the ORs, and we had to get our women's team on board with that. When we showed them the data, we were very easily able to accomplish that. So what's next for our work? We want to expand and adjust to the PACU and the LDR settings. So when we're looking at our fallouts as we go through each month, the dwindling number of fallouts, we're realizing that we need to adjust our checklist to some of these different environments to make sure that we're making it doable for our teams in these areas. Lastly, we want to explore the impact on admission hypoglycemia that this work has had. Certainly, if we can reduce the amount of hypoglycemia babies are having, we're able to reduce the amount of needle sticks they have and potentially other medications they may receive. Oops. This is my contact information. Please feel free to contact me if you have any questions or you would like to see our tool that we used. We will gladly share it. If you'd like to talk to any clinical members of our team, I would be happy to put you in touch with them. Thank you so much for listening to our presentation, and I wish you all the best in your work in improving outcomes.
We are grateful for the opportunity to share our performance improvement work with a central line acquired bloodstream infections. Here at CJW Medical Center, we are committed and dedicated to reducing patient harm one line at a time. We are a multi-campus facility consisting of Chippenham Hospital, Johnson Willis Hospital, and our freestanding ED, Swift Creek. With over 750 beds, nearly 3,200 employees, and over 1,400 members of the medical staff. We serve the metropolitan area of Richmond and surrounding counties. We also offer comprehensive services, including cardiac care, neurosciences services, orthopedics, maternal infant health care, and pediatrics. Each day, we use our mission statement as the guiding principle for the care we provide. Above all else, we are committed to the care and improvement of human life. Each year, we perform an in-depth year-over-year analysis of all of our hospital-acquired infections and other quality metrics. We identified in 2008 and 2019, we had an average of 20 central line associated or acquired bloodstream infections. In addition, our standardized infection ratio, which shows the actual number of infections over the predicted number of infections, increased. This was quite unacceptable to us. And as a healthcare organization, we are well aware that hospital-acquired infections have negative impacts, including complicating our patients' current course of treatment, extending their hospital stay, and of course, the increased cost. Again, this is not where we want it to be. Therefore, we became preoccupied with our data and our patient outcomes and wanted to change the trend. We completed an intensive assessment of central lines in our facility, and we identified the following: a perceived increased use associated with our patient acuity. We began focusing on our patient population, which showed complex patients with several comorbidities, including our patients with end-stage renal disease who would have temporary dialysis catheter access, heart failure patients receiving inotropic medications, our oncology patients with long-standing implantable access ports, and also those patients that required long-term antibiotics but with limited discharge options. We further looked at people providing services. We did have a contracted dialysis service that accessed central lines. In addition, we looked at clinical practices and found inconsistent insertion, maintenance, and blood culture practices. As we evaluated alternative options to a central line, we looked at midline catheters. Unfortunately, we did not have a midline catheter placement service.
We quickly moved from assessment to recommendations and putting those into actions. We had three major categories. The primary category was decreasing our device days. As stated earlier, we indicated that there was a perceived need due to acuity for central lines. We found that often we were not examining closely enough options to central lines. Therefore, we put into place a daily line review. It was completed every day, twice a day, even on weekends and holidays. We remained preoccupied with reviewing our lines on an ongoing basis to look for options and any unnecessary central line days out there. Additionally, we created a vascular access team. This was a team of nurses who were trained to put in peripherally inserted central line catheters as well as midlines, something we hope to increase. They also were experts in getting peripheral IVs in cases where others might not be able. Finally, we increased the robustness of our interdisciplinary rounds, engaging all disciplines in thinking about what the alternative to central lines were. Our physicians, our nurses, and even our other disciplines, including pharmacists, were engaged in finding alternatives. We also looked at appropriate insertion and maintenance. While we found insertion overall to meet the standards that we desired, maintenance was where we had a true opportunity. Therefore, we started with the basics of education. CHG bathing and line maintenance. CHG bathing for all patients with central lines has been implemented throughout our hospital. Additionally, we have assured that competencies are in place from an individual giving a CHG bath. That includes always moving from clean to dirty and wiping over dressings to assure true protection. From a line maintenance perspective, we not only audited our staff nurses at the bedside, but also worked with our contracted services of dialysis, doing audits on connections and disconnections during the dialysis routine. Infection preventionists were everywhere rounding. They were giving impromptu huddles and doing impromptu observation throughout the building. Staff were engaged and anxious to learn as well as improve their standards of care. We implemented alcohol impregnated caps, and again, we audited for use. Articles told us that while individuals were excited to get a new product, they often failed to use them, and we assured that we were using them at least 75 to 80% of the time. So the bottom line is our cry was audit, audit, audit after we educated, with immediate feedback as far as opportunities. Finally, we looked at the appropriateness of our cultures. We often found there are central line associated bloodstream infections were being found on the third and fourth day of admission. So we questioned whether we were really assessing the true nature of the central line on admission, including whether it possibly needed to be changed and or there may be an infection brewing for which we probably needed blood cultures on admission. I will show you our present on admission algorithm on the next slide. And finally, we educated on only using peripheral cultures versus drawing from the line. That is taboo here at Chippenham and Johnston Willis hospitals, and we try to always draw peripherally. While that may not always be the case, we do our very best to avoid drawing from the line, even for lab work. This represents our line present on admission guideline. This was created with input from our physicians as well as nursing staff. It was endorsed by our Infection Prevention Committee as well as our Medical Executive Committee. As you can see, with the line present on admission, the vascular access team is consulted and is to see the patient within 24 hours. Yes, our vascular access team is here Monday through Saturday and often come in on a Sunday to make rounds. Recommended line removal on admission if any of these symptoms were present. And then if these symptoms occurred on admission day number 1 or the following day number 2, again, with that assessment, we considered line removal and blood cultures at that time. Recommended blood, bacterial, and fungal cultures for line present greater than 1 week as an outpatient, knowing that we did not know how that line had been cared for, patients receiving TPN, and lines being accessed at home for home IV medications, drawing at least 2 peripheral cultures. This proved to be very helpful, particularly in the beginning. We always review our line list and look for present on admission still to this day, but in the beginning, it really generated great conversation between our infection preventionists and our physicians, who quickly learned the algorithm and no more needed as many calls as they did in the beginning. This word cloud represents probably what would turn into be multiple slides. But what we wanted to reinforce here was how often we were talking about central line bloodstream infections and what we were doing. Here at Chippenham and Johnston Willis, we are going what is called SLIM. No, it's not a new diet, but what it represents is our 4 major categories of opportunities and priorities: sepsis mortality reduction and use of the bundle, line management, infection prevention, and mortality reduction. Obviously, the L and the I fit right in with our CLABSI reduction strategy. And so on a regular basis, being daily, weekly, and monthly, we would talk about SLIM. We would talk about our process metrics as well as our outcome metrics. We drilled down to unit-based data, which was used by unit-based councils on the various units. And we also provided days without a hospital-acquired infection, CLABSIs, back to the units so that they might celebrate on units when they had reached 30 days, 60 days, etc. We used huddle tips on a regular basis to initiate education and then to reinforce education, but never did we use just written huddle tips as the only measure to do education. We were out there with IP rounds everywhere, talking with staff and talking with leadership. And leadership was reinforcing what we provided information to them back to the units. Lessons learned. We quickly learned that 0 can be achieved. And we actually achieved it for 6 months plus at each hospital for our central line associated bloodstream infections. We learned that everybody must be informed and committed. And we actually reached that commitment across the organization. We used data transparency and continuous sharing because that was essential to our success. And here is our current situation. We have decreased central line associated bloodstream infections for this year through November by 68%. This represents a true length of stay reduction for our patients and a better outcome, not to mention the savings, anywhere from roughly $250,000 to over $1.2 million, depending on what statistic that you're using. Our standardized infection ratio also decreased significantly, as displayed on this graphic. So therefore, we continue the journey, we continue to chase 0, and we continue to improve in reducing the number of central line associated bloodstream infections and our related SIR rate. Attached are our references. Thank you very much.
Hi, this is Patty Slatum, and I'm with the Virginia Geriatric Education Center at Virginia Commonwealth University. Thank you for the opportunity to share with you today our program, Mind Your Meds, which focuses on safe opioid medication use and disposal for older adults. This program is a partnership of the Virginia Geriatric Education Center, the Health Quality Innovators, and Virginia Navigator. So why Mind Your Meds? Well, we all know, I think, that addressing the opioid crisis is complex. And one component is that legitimately prescribed opioids and other medicines are getting into the wrong hands, contributing to the opioid epidemic. And there is a need to confront the public's mindset of saving medications that are no longer needed in case we might need them again in the future. These medications that are sort of saved but not needed, have the potential to get into the wrong hands. This program is designed to enhance older adult and family caregiver self-efficacy in medication disposal through an accessible, targeted educational intervention. A little bit of background. Incorrectly using prescription and over-the-counter medications can have serious consequences. And one of the kinds of problems that can occur is when medications are disposed of improperly, they can put others at risk for harm, or in the case of opioids, of addiction. And opioid medications are particularly high risk in this regard, and older adults may be of particular concern as vulnerable to having those unneeded medications used or diverted by others. So the primary objective of our program is to encourage older adults and family caregivers to clean out their medicine cabinet and dispose of all medications that are no longer needed, and especially attending to opioid medications. Our target audience is older adults and family caregivers, although the materials could be used by other groups as well. The intervention itself is a 30-minute educational program on medication safety and disposal, and it does focus on opioid medications and general medication safety. The outcome that we're looking for is whether or not participants report cleaning out their medicine cabinet after engaging in the program, and whether or not they invite others to do the same. It started off with a pilot program of an in-person educational intervention. It was delivered to older adults at several Area Agency on Aging program sites in Virginia. And of course, once the COVID-19 pandemic became prevalent in our area, we were no longer able to have these in-person educational programs. So in response, we partnered with Virginia Navigator to offer the educational program online on the Senior Navigator website. So what does this program entail? Well, we ask that individuals watch a short video presentation. Then they have the opportunity to let us know what they think about it and provide us with a little bit of information and about their intentions on using the program information to clean out their medicine cabinet. And then we hope that they'll then take that information and go ahead and clean out the medicine cabinet and invite their friends to do the same. We send a follow-up email to those who share an email address with us in about 2 weeks, asking whether they've cleaned out the medicine cabinet. So what we know so far is results from our pilot live program. We had a pharmacist from Health Quality Innovators provided about a 1-hour safe opioid medication education program where they were able to answer questions live. And 40 participants were asked to take action to go home, go through that medicine cabinet, discard expired and discontinued medications. And they were asked to encourage a friend to do the same. And at a follow-up meeting, 28 participants said that they had actually done that. And that, well, 20 out of 28 had actually done that, and 13 asked their friends to do the same. So a fairly high proportion of those who were asked whether they did it claimed that they had. We had a second pilot live program evaluation at 4 senior centers in Southwest Virginia. And here the pharmacist provided the presentation again, and 78 participants were asked to take the action of cleaning out the medicine cabinet. And in this case, 32 reported that they cleaned out their medicine cabinet, and that 4 of their friends had also done the same. So we can see that in the live presentation format, people at least have reported that they have taken action with the information that was provided. Our online program was launched in October of 2020, and uptake has been much slower than we expected. Our early program marketing efforts basically were sharing the link with seniors and family caregivers in a pretty non-specific way, and doing rapid cycle PDSA to help us improve this implementation. We have now revised our landing page on Senior Navigator to make it more friendly. We've shortened the online evaluation instrument to try to encourage people to fill it out. And we're offering an incentive to complete the evaluation by being entered in a drawing for an Amazon gift card. And lastly, we're developing materials now to assist healthcare providers and health systems to be able to refer patients to the program. In our pilot program that was live, we had a pharmacist speaking directly with people, and we're hoping that by deploying this program through healthcare providers and health systems, that we would see more individuals able to take advantage of the encouragement to clean out their medicine cabinet. So Mind Your Meds is an easy to access educational program on the Senior Navigator platform to encourage older adults and family caregivers to go ahead and get rid of those unneeded medications. It's available for use in many settings where opioids are prescribed or dispensed simply by sharing the link to the Mind Your Meds program. And this could happen at hospital or emergency department discharge, in primary or specialty care when opioids are prescribed, and of course in pharmacies when opioids are dispensed. One potential limitation that we see is that we don't have evaluation data yet from the online version. So we may find that our results are not the same as what we saw in person. And we do know that there's technology barriers that may limit the use for some older persons and caregivers. However, we hope by using this type of a format, particularly during a COVID pandemic, that we would be able to reach a broader audience with this important information. So this is really a call to action. We hope that you'll share this resource with patients, providers, and community partners. There's a link to the program itself on the slide, the consumer-facing program. We also have a link to some consumer handouts that you can use to simply share with a patient or a client to encourage them to go to the website. And it has the website information on the flyer. And I really think this is a chance for us all to continue to do our part in combating the opioid epidemic. For more information about using this program, please feel free to reach out to myself or Cindy Warner at Health Quality Innovators. We would be happy to share our materials as we continue to develop them. And hopefully we'll be back to live presentations at some point, and we'd be happy to talk with you about that as well. Again, thank you for your attention to this the information that we have, and we really encourage you to share this widely within your health systems. Thank you.